Hi everyone, welcome to the 4D show. I am Dr. Prashant Arun, consultant physician and diabetologist at MV Hospital for Diabetes, Chennai. So today our topic is going to be problems in diabetes care in India. So when we say diabetes care, most of the patients either don't even come to the doctor to detect diabetes or any other disease. But mind you, detecting the disease and getting treated early is definitely better, and it is way cheaper compared to treating the complication and spending on the complication. So it is always better that you get detected early and get treated early. But most of the patients don't get this, and they really either don't know about the disease or they don't really want to come and meet the doctor. So, for this, we have with us today Dr. Sandeep Julka. He is a MD medicine, a DM endocrinologist. He's finished his MD and MBBS from the MGM Medical College, Indore. He's finished his DM from Lucknow. He's a senior consultant, Department of Endocrinology, Apollo Hospital, Indore. He runs the healthiest endocrine center in town, the Radiance, practices both adult and pediatric endocrinology for the past 18 years. So we have somebody very senior who's going to be telling us about diabetes care and answering all our questions and clearing patients' doubts and doctors' doubts on multiple drugs and diet, etc. And he'll be telling us all the importance of the SGLT2 inhibitors, etc. But what mainly caught my eye is he's not only a doctor, he's an IMA lawn tennis winner, doubles and singles for the past 4 years, and he runs half marathon. At his age, he's actually giving importance for fitness also, because it's very easy to tell the patients to stay healthy, do regular exercise. But when the doctor himself sets the example, it is definitely way very well. So we are going to be listening to Sir, and Sir is always an energetic person. So on to you, Sir.
So thank you very much, Dr. Prashant, for that kind introduction. And the topic, so to speak, is hitting the nail on the head, the problems faced by us in India for diabetes management. And our problems are very different from those faced by doctors in the West. One is by sheer numbers, and we are resource constrained. Can I have my slides, please? Can we have the next slide, please? So there are several problems faced by us, and it is a challenge. And we all know that diabetes is a pandemic across the world. And the latest statistics from IDF say that every 5 seconds a person dies due to diabetes, and every 70 seconds a limb is lost due to diabetes. So we have to be very, very careful. So one is lack of awareness. Diagnosis, screening facilities are not there. We do not have that many qualified healthcare professionals, financial constraints, social barriers. Next, please. Cost of treating diabetes is humongous. By IDF Atlas, in 2021, the world spent $600 billion to treat diabetes and its complications. And as you can see in this pie chart, there are various modalities where a person ends up spending through the pocket. Most of the patients spend through pocket, they're not insured. Next, please. So what are the barriers related? So barriers can be at the level of the patient, and the rest can be at the level of medical professions. Professional barriers can be there. So one is awareness, lack of awareness, denial. There is denial when somebody is diagnosed with diabetes. Immediate benefits may not be seen. Lack of social and familial support, lack of trust in doctors, lack of adherence of the guidelines. So any chronic medicine, it is known that there is 50% of drug defaulting. So one has to be careful. At the level of the medical professionals, I think the biggest is the problem is the clinical inertia. Not increasing or intensifying therapy at the right time is a big problem. And then training, of course, is a big lacuna. Next, please. So what can be done? So there have been brilliant advances in diagnosis, management, and even monitoring of diabetes. And some of these drugs which have really changed the way how we manage are the DPP-4 inhibitors, the SGLT2 inhibitors, and the GLP-1 agonists, both injectable and now oral. Oral semaglutide is now available. They have really changed how we manage diabetes and the outcomes of diabetes. Next, please. So what are the possible solutions? We can empower the patient. So one is educate, power. E is educate patients, empower them. And then, of course, keep that in mind that the economic aspects of diabetes has to be taken in, both the therapy as well as the comorbidities. Then what can be done if, for example, somebody who's sitting in Indore or in, say, for example, in Chennai, you can have a telemedicine center and lots of centers can join in and people can come. You can do telemedicine. We all seen that in COVID era, that telemedicine was really very much used.
So, sir, that is, we have come to the end of the slideshow presentation, sir. So we will just take up some questions, but the questions is because we've got audience, both doctors and we've got non-medicals. So there are going to be some questions which are very basic and some questions for doctors also, sir. So to start with, the first question I would like to ask you is, sir, usually these SGLT2 inhibitors, that is the class of drugs that is now actually booming the market as currently, we generally tend to stop the SGLT2 inhibitors once the patient develops urinary tract infection. But in these patients, can we restart the SGLT2 inhibitors once the UTI is treated and once the urine culture shows negative? Can the patient be restarted with the SGLT2 inhibitors, or is he still at risk of developing the urinary tract infection, sir?
Yeah, that's a very important question. In fact, every day we get these questions, not only from patients, but the doctors as well practicing in the periphery. So my practice is that for each drug, you have a risk-benefit analysis. For a patient where you need to give SGLT2 inhibitor, for example, one with underlying CAD or with congestive heart failure, they are not drugs of choice, and now they can be given even in non-diabetics for congestive heart failure. What I would do is withdraw the drug for some time, treat the UTI or the fungal infection, and then restart it, because you know that the benefit in mortality is significant. We also know that the urinary tract infection is most of the time lower urinary tract infection. It is never pyelonephritis, and the genital infection can be taken care of easily. So what the message should go, always when you're prescribing SGLT2 inhibitors, make sure that you explain to the patient of proper perineal care. Beyond that, I think they can definitely be restarted.
Yes, sir. Thank you, sir. So, next question is, generally we say that the SGLT2 inhibitors don't work or is not more effective when the EGFR is less than 30%. But maybe a person who's having heart failure with maybe an ejection fraction of 25, which EGFR of 25, 22, what would the role of SGLT2 inhibitors be, sir? Not for the diabetes part, maybe for the heart part, sir?
Yeah. So since they are working on the convoluted tubules and we need to have that many number of tubules for it to act, so definitely these drugs will not work, and when you have as a glycemic control medicines. Now there are various pleiotropic effects. Although I do not use these drugs when the GFR is very low, there are other drugs like the valsartan sacubitril combination given to patients with congestive heart failure, where these drugs come into place when you have hypotension. Then you cannot give valsartan sacubitril, then you have to give these drugs. So I have never tried it in patients who got very low GFR, but you never know. You can give them, at least there is no harm. But then the drug of choice when there is renal failure and you can control the potassium is valsartan sacubitril.
Thank you, sir. Again, now that you have mentioned about the valsartan, sir, in case we are stopping these drugs of valsartan and sacubitril in view of hyperkalemia, because most of the patient comes and ask us, once they start on valsartan and sacubitril, they say, my doctor told me that my potassium is going up, so my doctor has withheld this drug for some time. But once the potassium has been corrected, can we restart these drugs, sir?
Definitely.
beneficial to the heart.
Oh, yes. So sometimes what happens is you've started an ACE inhibitor and you've given sacubitril valsartan, and some patients are on a potassium sparing diuretic, something like an aldactone may be there. So most of the time you find that the potassium is hovering around 5, and then on top of it, if there is other problems or a mild renal failure, then the potassium shoots up. So you have to be very, very careful. In our country, the follow-up of the patient may not be there. He or she may come after 2 months, and then they have a problem with high potassium. So you can definitely restart. Uh, Only thing is you make sure that you monitor potassium. That is all.
Sure, sir.
Yeah.
So, and these SGLT2 inhibitors, again, we say drink more water because we always take it as a thing to tell our patients, please drink more water when you give this SGLT. But what does this more water mean, sir, during giving SGLT2 inhibitors? Because there are few people who say, I drink lots of water. We tell how many? He say 1 liter. So, according there is, what is this more water, sir?
So I think when SGLT2 inhibitors were launched, the problem that people thought that they cause a lot of nocturia or polyuria, that is not there. There is only one extra void which is caused by those SGLT2 inhibitors, and it is not that you find people going into the bathroom every night. That is one. Secondly, even elderly, we found that it does not increase their nocturia. So you just have to tell the patients, take adequate amount of water, your 8 to 10 glasses of water, which is adequate. Beyond that, if we tell them, and so sometimes you can have a primary polydipsia side kind of a situation where you emphasize the need for water so much that they drink a lot of water. And especially in people who have congestive heart failure, where you are limiting not more than 1.5 liters of fluid every day, more water can cause havoc. So I feel that you should not stress on that point. Just tell them to keep their perineal area clean, and at the first instance when they find there is urinary tract infection or general infection, to inform us. That is all.
Yes, sir. Sir, another question generally asked is because people now mostly we see doctors in the peripheries, doctors everywhere, they are prescribing patients on SGLT2 inhibitors. Can you just tell us the importance and the benefits and all the effects of these SGLT2 inhibitors, sir? What all can it protect, complications of diabetes? Because definitely the expenditure of treatment is going to go up once the patient develops diabetic retinopathy, nephropathy, or any heart diseases. So, by spending on this tablet, can the patient actually save on the complications, sir?
Yeah, that's a wonderful question, Dr. Prashant. See, uh, 10 years back, when we wrote an anti-diabetic drug, we could never promise the patient that we would reduce his cardiac mortality or cardiac events, cardiovascular events. The first time when these drugs came, SGLT2 inhibitors and the GLP-1 agonists, we are able to tell our patients that, okay, now we have a drug where we are going to control your blood sugars, not cause hypoglycemia, cause weight loss, and bring down your cardiovascular mortality and morbidity. So that is one important. Any therapy which brings down blood sugars by 1% reduces 30% microvascular damage. All those microvascular complications reduce 30% that we saw in UKPDS, 1% reduction. So it is benefit for everything. If you remember, we used to say there is a HbA1c weight paradox. Whenever you try to reduce HbA1c, the weight goes up. For 1% reduction in HbA1c, we used to cause 4 kg weight gain. By SGLT, by sulfonylureas and insulin, weight gain was there. But by using GLP-1 agonists and SGLT2 inhibitors, for the first time, we can say we are controlling your blood sugars, but causing a weight loss as well. So the benefits are so many that these drugs have been a boon for our patients.
Thank you, sir. So, next thing is, sir, that we spoke about SGLT2, weight loss, all that, because sulfonylureas, insulin used to cause weight gains, but this SGLT2 is helping you weight loss. Can we use these tablet purely for weight loss? Instead, when the patient does not have diabetes, definitely patients are using these SGLT2 inhibitors for the cardiac aspect. But maybe the patient is not a CAD, does not have diabetes, sir, because we see many people use this for weight loss because they come and ask us, sir, can I take these tablets for weight loss alone? Maybe the SGLT2 inhibitors or the GLP-1, sir. How is your opinion on taking it for only weight loss?
So let's talk about metformin as well. Metformins we give to girls with PCOS for weight loss, which helps in reduction in insulin resistance as well. I do not suggest people take SGLT2 inhibitors for weight loss, except for the 300 milligrams of canagliflozin, which is a large dose which may cause some weight loss in non-diabetics. As GLP-1 agonist, for sure, we know that liraglutide is approved for weight loss in the US. And recently, Elon Musk said that he takes oral semaglutide in that higher dose for weight loss. Now it's going to become very popular. Some of my doctor friends have tried oral semaglutide in India at a lesser dose for weight loss. So I think GLP-1 agonist will be and now we have that tirzepatide coming, which is a GLP-1 GIP. We are doing a long-term cardiovascular outcome trial with tirzepatide in Indore. That is going to come in a big way. It has already come in a big way for weight loss as well as for cardiovascular mortality reduction. So GLP, yes, for weight loss will be there. SGLT, not so much.
I always see, sir, because when we say GLP-1, because of the cost factor, people just think it's a magic. Because I had one patient who I gave him GLP-1. He came back to me after 2-3 months and he said he's not lost weight. I said, why you didn't lose weight? What happened? Like, sir, you gave me one magic drug. It's so expensive. So what I did, I took the drug. I had biryani, ice cream, this. I had party. I did everything, sir. I'm paying so much. So I said, see, the problem is the drug will work, but you should not go against the drug. Just because you're paying so much, it doesn't mean the drug is good. People actually connect the cost of the drug with the action of the drug. That's actually a big mistake people do.
Oh, yes, I agree.
So what is your opinion, sir? Now these SGLT2 inhibitors come because now that we have a plethora of drugs, we have the SGLT2, we have the DPP4, we have the sulfonylureas, we've got lots of OHAs. Would you recommend taking combination pills like we've got the SGLT2 inhibitors with the DPP4 inhibitors like the DAPA with Sita-DAPA with vildagliptin combination? And there is now coming the DAPA with Vilda with metformin, DAPA with Sita with metformin, triple drug combination. Does it actually help reduce the patient's pill burden? Or would you recommend giving the SGLT2 separately and the DPP4 inhibitors separately, sir?
So, Dr. Prashant, I'm all for reduction of pill burden. So, I'm for reduction of pill burden. I'm for reduction in cost because cost is exorbitant, but we are happy that now since that it is out of that DPC and all, it is being produced in India and now we've got cost which is less. Pill burden reduction is the best thing you can do for your patients. So I'll give an example.
Yes, sir.
Today a patient had come from Philippines.
Okay,
he's an Indian working in Aditya Birla Textiles in Philippines. There they don't have a combination. The physician there had written glimepiride, pioglitazone, metformin, SGLT2, DPP4. And I was surprised. A tablet of 2 milligram of glimepiride there was 95 rupees. And DPP4 was lesser. He was taking linagliptin and it was less, almost similar cost as in India. So anything, and he was taking so many drugs. Here I got a combination of 2 drugs and that is all. His 8 medicines became 3 medicines or 2 medicines. So anything you do to reduce the pill burden and the cost is going to help the patient.
Well said, sir. Because when the patient itself feels that the prescription has come down short and individual costs of medicines are going to go up when these combination therapies are much more better. Sir, like you mentioned now, glimepiride is being costly there. But my question is, this SGLT2 inhibitors coming into the market, has it kicked off the sulfonylureas or does sulfonylurea still have a say, because SGLT2, now everybody is talking about SGLT2, oral semaglutide, and GLP-1s.
Hmm.
Nobody is talking about sulfonylureas, sir.
Oh, so that is wrong. See, we have to be realistic. DPP-4 inhibitors reduce A1C by 0.5 to 0.6, unless combined with metformin at the most 1. SGLT2 inhibitors again 0.6, 0.7. Again, they have to be combined. So when you want a reduction, a robust reduction in HbA1c, you have to give sulfonylureas. Later on, and maybe you can withdraw them after a few months when the patient is exercising, following a diet proper, has reduced some weight, then you can reduce it. But sulfonylureas are here to stay. You cannot do away with them.
Sure, sir. So, does SGLT2 inhibitors have a role in fatty liver, or is it only that when SGLT2 inhibitors are given and the weight loss, which actually helps in the fatty liver, or does SGLT2 have a direct role in reduction of the fatty liver, sir?
Yeah. And I think there was a study done from Medanta, Dr. Amish Mittal, and everybody. They've done a study, and I'm sure many people have done it. They did, and I think there was a biopsy proven benefit of using SGLT2 inhibitors and GLP-1 agonists in fatty liver reduction. The mechanism of action is not just weight loss. I'm sure there must be a pleiotropic effect, some antioxidant, reducing some free radical injury, or so there are so many mechanism actions of SGLT2.
Sure, sir.
So I think there is action which is different from just weight loss.
Okay.
But it's significantly benefiting. So we know that almost 80% of our type 2 diabetics will have fatty liver.
So, which are the patients you would choose to put on SGLT2 inhibitors, sir? What kind of patients would you prefer to be on SGLT2 inhibitors?
So
Would you,
if possible,
just a small alteration, or would you choose it as a first line therapy itself in the treatment for diabetes, sir?
so if I have my way, I'll put everybody on SGLT2 inhibitors. Unless somebody has very high blood sugars, has osmotic features. Otherwise, I want to give it to everybody because now they're not expensive, no significant side effects. So, but of course, those with underlying CAD, definitely, then there are more multiple benefits of SGLT2 inhibitors. So, in a preventive also, there's always a controversy. Is there something like a preventive cardiology? What do you want to do? So would you like to give statins or aspirin or SGLT2? So we all know that a type 2 diabetes patient at diagnosis loses 6 to 8 years of one's life. The major cause of death in a diabetic patient is cardiovascular. So when you do the risk reduction, you want the patient to exercise, lose weight, stop smoking, control blood pressure, control lipids, then add drugs which can prevent cardiovascular problems like SGLT2, GLP-1 agonists. Don't forget pioglitazone, also a drug by IRIS trial, and everybody, all they have shown that it is good. So I think if possible, you use it in as many patients as possible.
Sure, sir. Thank you, sir. So next is just move on to some basic questions for our general public, sir, because when do we actually start a patient on insulin, sir? Because because we say insulin, people run away from the clinic or they go off to some other doctor. But is it okay to start a patient on insulin? When do we start the patient on insulin? How do we pull them out of insulin? And when we pull them out of insulin, can we put them on these SGLT2 inhibitors and, bring them out of the insulin? Or with the insulin, when we give the SGLT2 inhibitors, what are the benefits that we get with the patient, sir?
So, as rightly stated, people have a problem with fear of needles, and insulin, they take it as the last step, and this is the last, and I think I'm at the end of the road. But in my clinic, 90% of those diagnosed diabetes get insulin initially for 7 days. One, because when the HbA1c high, you want to bring down glucotoxicity and lipotoxicity faster. I give them insulin for 6 days. there is beta beta cell preservation. Then I shift them to 0.5 milligram glimepiride, metformin, pioglitazone, DPP4, whatever I want to give next. The advantages of giving metformin in appropriate dose, SGLT2 in appropriate dose, GLP-1 with insulin is that you negate the weight gaining effects of insulin. So again, if I start the topic of reversal and remission, the discussion is going to continue. So my suggestion to doctors practicing is, please put all your patients who've been diagnosed with diabetes, when the sugar is high, A1C of 9 and above, 10, 11, 12, put them on insulin for 6 to 7 days. Give them metformin, pioglitazone. You are going to give them, do a big service in preserving beta cells.
Sure, sir. Sure, sir. So another question frequently asked is, do we stop this SGLT2 inhibitors prior to a patient going into surgery, or when the patient is admitted with, because most of the patients with diabetes present with diabetes foot infection and sepsis and something like that. So at times, if the patient is maintaining a HbA1c of 5.5 or 6.5 or 7, it is maintaining a very good glycemic control. Do we stop the OHA? First question is, do we stop any OHA and convert the patient to insulin just till the time the patient goes to surgery and comes back? Or if the patient is on SGLT2 inhibitors, is it better to stop the SGLT2 inhibitors, go in for surgery, come back and restart, sir?
Yeah, very good question. We know that SGLT2 inhibitors can cause euglycemic ketosis. Any patient who's in the ICU and is moribund, don't give SGLT2 inhibitors. Prior to surgery, stop metformin. SGLT2 inhibitors, even if you stop, it is good. Patients who are undergoing laparoscopic surgeries, clear surgeries, just cholecystectomy, you need not shift them to insulin. Your OHAs will do well, and if the glycemic control is good. But for somebody who has an infected wound, is on 4 milligrams of glimepiride, then definitely you need to shift him to insulin. So each case requires its own management.
Sure, sir. Can you just throw some light on a healthy diet, sir? What would you call a healthy diet in a patient with diabetes, sir?
So India is as we say, it is unity in diversity. What Dr. Prashant has in his breakfast, lunch, and dinner, I may not have that in Indore. I will start my breakfast with poha, but me being a Punjabi, I may have parathas. So lunch will be roti chapati and some. But all said and done, the Indian diet across India, north, south, east, west, is a healthy diet. You will have pulses in it. Your sambar will have pulses, will have vegetables. So I think wholesome diet is good. But yes, when we talk about diabetics, we want them to control their carbs and increase their proteins. Okay. So carbs, okay, we say that have multigrain atta instead of using that. Take rice without the starch. Few tips. Don't take even your multigrain bread is no use. So all these basic, because people come and say, evening I take tea and biscuits, but they end up taking 4 biscuits. Hum to Mari biscuit khate. 4 biscuits of Mari is taking like 2 chapatis. So all this has to. So you need to have a nutritionist who takes a dietary recall and then treats.
Sure, sir. Thank you, sir. Sir, another thing is about vitamin D, sir, because most of them, when we say check your vitamin D, they just think it's vitamin and they'll be like, okay, I'll check it later, and they move out of the clinic, sir. What is the significance of vitamin D in a person with diabetes, and how could that help in controlling their diabetes, sir?
So, but I think it's a wonderful question you asked. And I've been going across in India talking about vitamin D, being an endocrinologist. The biggest danger now with vitamin D is toxicity. Past 6 months, we've had patients going on dialysis with hypervitaminosis D and hypercalcemia and renal failure. Everybody is giving injections right, left, and center, giving them vitamin D weekly, 60,000 units. That is not to be done. The message from this talk should be very clear. See, the nutritionist gives vitamin D, the ENT doctor, the gynecologist, the orthopedician, any Tom, Dick, and Harry will give vitamin D to everybody. Unless you ask your patients and you start writing, so please ask your patient, wo weekly wala medicine liya kya? So there is a daily requirement of vitamin D and calcium which is to be given. And those with vitamin D deficiency, there is a controversy in US as well. Institutes of Medicine and Endocrine Society, they are at loggerheads. What is the normal? I will tell you, 30 nanogram per ml of vitamin D, 25 hydroxy vitamin D is normal. That will be something like 120 nanomole per liter. You do not need more than that. Taking 1000 milligrams of calcium and say about 600 IU of vitamin D daily is good for all age groups. Toxicity is bad. Whether vitamin D helps in controlling blood sugars, there are so many pleiotropic effects of vitamin D. There was, I think, Dr. Hollick's talk today. He's known as the father of vitamin D. I think those things may be there, but you have to stick to your anti-diabetic medicines for controlling blood sugars. But vitamin D is important. It is known that adequate vitamin D increases your longevity, reduces your autoimmune problems, Alzheimer's, so many things. So maintain it around 30 nanogram per ml.
Thank you, sir. So with this, we've come to the end of our show, sir. We had a wonderful time, sir, and you gave us so much of knowledge about SGLT2s, vitamin Ds, diets, etc. And it was really nice talking to you. It was really energetic. So I'm really happy to have been hosting this session with you, sir. Thank you. Thank you so much.
Thank you, and Jai Hind.